My name is Terrence Barkin, and I'm the Executive Director of the Graphene Council, the largest community in the world for graphene producers, researchers, application developers, and end users. We have hosted the Graphene in Healthcare and Medical Applications Conference Series, and the video you are about to watch is from that series. Well, this next presentation is we asked both gentlemen to present because of a paper on this electroceutical research for treatment of diseases. And this gives us a really different vector and look at the use of graphene in the healthcare and medical applications. So with that, gentlemen, please tell us about your work, and it's all yours. So thank you.
All yours, Mario.
All right, thank you. So I'll be sharing with you. First of all, let me make a disclaimer. I'm the founder and chief scientific officer of two companies, Nerve Solutions and Regenerative Bioelectronic Medicines Incorporation, and they're in the process of licensing some of this technology that we'll talk to you about today. And there is a conflict of interest program already established at UH. So first of all, very quickly, chronic diseases should be not surprise to all of you that is a number that a number of people have of people in the US, approximately or 6%, have a chronic condition, which could be the hypertension, arthritis, diabetes, all the main conditions that Terrence have already mentioned, right? And this number continues to increase as the number of people in the world continues to, as the population increases as well. So the idea here is the question that we're going to face is, what are the new technologies and how that are coming to bear and how they can impact in a positive way the treatment of some of these conditions? And we'll talk about some of them today. Let me first explain what neuromodulation is. So neuromodulation is the alteration of nerve activity through a targeted delivery of a stimulus. And that could be electrical, could be chemical, and in some research instances can be also optical or magnetically. The idea there is to recognize that many of these modalities of neuromodulation have already been applied and are clinically in use for the last 20 years, like vagus nerve stimulation for the treatment of epilepsy or depression. Deep brain stimulation for the treatment of Parkinson's disease or depression is another type of example. And several companies and patients have been benefited from the use of epidural electrical stimulation to the spinal cord for the treatment of pain. Definitely, you may also remember the use of sacral neuromodulation for the treatment of overactive bladder syndrome. So how is bioelectronic medicines different from neuromodulation? It differs because it uses miniaturized devices. It uses targeted nerves, so very selective. It also not only targets the neuromodulation, but also the deciphering, the decoding of the neural signals between the organs. And it aims at selectively controlling a single organ at a time. So this is particularly pertinent to internal organs, which we rely on to be alive and healthy: heart, lungs, kidney, and so on. It's based on identifying a nerve target, a signal that can be applied, therefore then the terms electroceuticals, and a device that could be implantable. You can imagine that as being miniaturized as well as being wirelessly powered and wirelessly able to transmit data back and forth. This bioelectronic medicine field as a whole represents about a 22.6 billion market and is projected to increase up to 60 billion in years to come. So it's not an insignificant market as it is. So when you think about organ neuromodulation, then you probably realize there are already a number of applications either in the pipeline or already some products available for patient use. Migraine, asthma, arrhythmias, obesity, urinary incontinence are some of these examples. Some of those are in the form of implantable devices. Some of those are in the form of wearables or cutaneous devices. And I'm not going to have the time to cover the difference between both of them, but suffice to say that this field continues to explode. Now, we've been interested in the use of graphene as a tool, as an electrode, to interface their peripheral nervous system, particularly the autonomic nervous system. Now think about it. Your autonomic nervous system is named autonomic because you don't think about it, right? You run and your heart rate starts accelerating automatically. But in many of diseases and many conditions are a reflection of a abnormality to the way the autonomic nervous system is supposed to work, like hypertension. So can you imagine if you develop fibers or electrodes or miniaturized devices that can modulate at the organ level to compensate the disease? So very specifically, let's talk about rheumatoid arthritis. So we know that's a condition of inflammation of the joints. We also know that there is a number of the biology and the cellular and molecular pathways involved in this condition are very well understood, okay? Now, the way we treat them is by applying or recommending disease-modifying anti-rheumatic drugs or DMARDs. Now, if you think about it, just by the name of it, you know that you're not treating the condition at all. You're basically modifying the condition. And 90% of patients will receive methotrexate, as an example, for the first year. Unfortunately, within the first 6 months, some of them, 2 to 3%, will start getting a combination of drugs. And the reason is because, they will start failing to respond to traditional pharmacological treatments. The real important thing to realize is about 30% in year 2 and 63% by year 5 will stop these treatments because of the lack of efficacy. So the question is, what's next? What's next for these patients? And so Kevin Tracy at the Feinstein Institute a number of years ago reported that the brain controls the spleen, and therefore the spleen being one of the main organs that contributes to for chronic inflammation. He was basically suggesting if we can modulate the spleen function through the pathways that normally the brain uses, maybe we can then modulate inflammation. And he recognizes the vagus nerve as a target. And he basically says, look, if we target the vagus nerve, meaning that afferent kind of parasympathetic path, which will decrease the activity of the spleen, maybe we can then cope with chronic inflammatory conditions. He specifically targeted rheumatoid arthritis and sepsis. This was an incredible breakthrough in medicine as it is. And so the challenge since 2012 has been, can we A, understand better this pathway, and B, if we want to neuromodulate it with electroceuticals, what is the device that you're going to use looks like? Well, the device initially that was used to develop the proof of principle in the clinic was a commercial IPG or implantable pulse generator that you can see here with a coil electrode, which is normally and traditionally used for vagus nerve stimulation for other treatments like epilepsy. They were able to apply this into some patients out of the US, and they demonstrated that for some patients there was a clear recovery, which was quite dramatic. If you think about it, these are patients that have not responded to any pharmacological treatment anymore, and now with a neuromodulation of the vagus nerve, you can now have a reduction in inflammation and recovery of your daily life activities. This initial study was repeated very recently in 2019 by Mark Ginovese. He's the chief division of immunology and rheumatology at Stanford University, and reported that for a large cohort of patients, there was a significant reduction in the disease activity score using 28 points, basically, including C-reactive protein at 12 weeks. So this is now becoming a bit more solid evidence that points to the benefit of using electroceuticals. The device that is being commercialized currently by SetPoint is the one that you see there on the top corner. So again, vagus nerve stimulation approved by epilepsy, depression, that is being increasingly included as a potential treatment for a number of conditions: tinnitus, obesity, post-traumatic stress disorder, rheumatoid arthritis, as I mentioned, stroke, and a number of rehabilitation studies as well. Now, the problem with that technology being here, you can probably see here the electrode as is shown being implanted in a patient, this coil electrode, is that it also has some side effects. The main reason is because when you activate the entire nerve from the vagus, not only you're activating every single afferent fiber, even fibers coming from the visceral organs to your brain, but also fibers that go from the brain to your larynx and the larynx muscles. And therein lies the problem, because you can activate these muscles in an off-target manner, and you get voice alteration, hoarseness, throat pain, coughing, and other really not pleasant side effects. So the key question here is, can we improve on these otherwise highly beneficial therapy? So then we start thinking about, can we go into the spleen directly? Now, here is a drawing of the key. You have the liver, the aorta, you have the stomach, and out of near from the stomach, actually to the right, you'll see the spleen right here. And the spleen is normally innervated by a single splenic nerve, and then it branches into 3 different branches or 4 different branches. So the idea is, if we don't target the cervical vagus, not in the neck, but if we go near to the organ, automatically you get selectivity and avoid all the other side effects. So that's a very appealing idea. But then you start thinking about what electrodes we have available. And the electrodes that we have available are needle electrodes, planar electrodes, some of the ones that either ourselves have worked over the years, none of which could be used on a soft tissue like the splenic nerve. And I'll explain you why in a second. The other thing is that by then, Dr. Gordon and I have been collaborating for years, more than a decade. It has been a joyful and productive collaboration. So I'm really an honor to have been collaborating with him for a number of years. And he is a material expert. He's been working on reduced graphene oxide, and by 2015, he had already produced a fiber electrode that was made out of condensed single atomic sheet, large sheets, actually 2 micron large sheets of single atom graphene fibers, which he managed to align. If you have questions in terms of manufacturing and all the details on the chemistry, please direct them to Dr. Gordon Wallace. Here in the picture, you see how the fiber is very flexible. He, in fact, have to put some peg to provide some temporary scaffold to be able to put it into the brain. And he showed that in the brain, this fiber works as an electrode. How do we know that? The black thick area is noise. The vertical lines are single action potentials. This is the signature of an activated neuron. So that was good enough, but it's just not really what we needed for the spleen. By the collaboration and talking and working over a number of years, he was able to perfection these substantially. The perfection in part specifically involves coating the graphene with a platinized layer, which made this electrode incredibly sensitive. This came out in Advanced Materials in 2019. It's a flexible material, so it's like half of the things of a single human hair, about 40 microns. You can tie a knot. You can use it as a suture. I'll explain that more in a second. It has incredible surface area capabilities, but when you compare charge injection capacity with a specific impedance with geometrical surface area, it just comes on top of everything else that is available at the moment. Every other conductor or metaconductor that we can see, 300-fold more sensitive, 3 times more able to inject current, so you will inject current more effectively, flexible, strong, safer. The first thing we do is to put it through a muscle to see if it will be mechanically robust to suture, and we were able to do that and inject some electrical current, and you can see the muscle contracting. So that basically gives us the idea to call this a sutrode or suture electrode. You can also use that as a overknot electrode and use it to record. And down here you see these wavy lines are the activity of multiple neurons coming out of the sciatic nerve in the rat. So we're able to use that for stimulation and recording. And he did a number of testing. So you have the duration test over a number of cycles. The CV, the charge voltammetry doesn't change. The pulse characteristics doesn't change. The conductivity doesn't change over a number of bending cycles. Sorry, and it has a very initial storage or robustness testing and PBS soaking show very little decay. So all those were good indicators. We then use it in the animals. In here you see a actual suture going and separating the carotid artery. This is not, the yellow arrows are not the suture. The suture is the blue arrows. You can see that looping underneath the vagus nerve. And then we use nitroprusside to lower the blood pressure, and you can see how incredibly sensitive that is. And you know that because the lines, the vertical lines, are larger and they're higher than the noise. So the signal to noise ratio has to be 9 decibels. We also demonstrate that you can see the same activity in the vagus nerve by creating hypoxia, and then it's a completely reversible effect. So very good characteristics, but the challenge on the spleen is even further. These nerves in the spleen are traveling between an artery and a vein. Not only that, as they travel, and you can see them sandwiched between an artery and the vein, they are divided into fascicles. They're very difficult to see, almost impossible to put anything on them, and they're very, very tiny. They have about 400 really tiny axons. We wanted to do 4 of them because we got information in the rat, the 4 of them are very tiny. And then you can see what is the problem. The yellow arrow points where the nerve is. There's nothing you can do to put anything on it unless you dissect the tissue, which nobody will do in the clinic. So the ideal situation will put something on top of the entire thing. And that's what we did. We tied a knot over each one of them, the branches. And here are a specific nerve activity. So the waveform that you see are actual compound activity from individual branches of the spleen. We can show that when we do oxygen deprivation, there is an independent and selective activity changes in each one of these branches, will give us an idea that these branches are different among themselves, and they may regulate differently the spleen. This is a busy slide. I don't intend you guys to understand the whole thing, but suffice to say that the top part is the vagus nerve, and the yellow and green and white lines are different nerves able to select. As soon as we reduce the blood pressure, we can see some of the activity going completely down. Other ones are coming up, and some other ones will come later. We can recognize in the spleen what is the timing at which each one of these branches are activated, which is for the first time provided clear, decoded information from one of the main organs involved in chronic inflammation. So that was really exciting. Moreover, we were able to apply a specific electric stimulation in the subdiaphragmatic vagus nerve to show that in some charges, some electrical patterns can increase the activity at the spleen, and some others will completely reduce it. With this in mind, you probably now have an accelerator and a brake. You can now start thinking about the possibility of neuromodulating the spleen directly, which now gives you not only selectivity, but high level of control. So where are we going from here, and what are the other challenges? Well, first of all, if we can interface the nerves that control the spleen, we can do that with other nerves as well, those that control the kidney, the pancreas, and other internal organs. And we're doing that at the moment. Clearly, this is a very early stage scientific work. We're also very interested in translating this into a medical device, into something that could be making it to the long and challenging path to get a medical grade product and ultimately land into the clinic. There are other challenges are data sharing analysis. This comes with a huge amount of data. And we're talking about terabytes of data, continuous recording. So there's a lot of work on the back end. How does the electronics look like, and where are the data is going to be stored? And this is something that is not only particular to our work, but it's particular to the entire bioelectronics or electroceuticals field. So a number of issues with data access, sharing, selling, invasive is not invasive. So it's a very exciting field with a lot of promise. So what are the future trends? Multi-organ signal recording, as I mentioned before, mining and decoding neural data, understanding of neural circuitry to make complex targets accessible, and controlling dosing for specific medical conditions. Technology is here, obviously, University of Wollongong, Australia. Kesson Wang is a PhD student that worked with Gordon to produce the fibers. Alejandro Gonzalez is a postdoctoral, senior postdoctoral fellow in my laboratory, along with others having contributed to the development of these and current projects. The contact information for me is listed there, my email and my telephone number, as well as that for Gordon as well. And with that, I'm going to stop my presentation.
Well, Dr. Romero Ortega, thank you so much. That's a really, really, really impressive piece of work. And Gordon, thank you as well for joining us. We have just under 10 minutes for the last questions. And, of course, today's topic is graphene and medical applications. Your work here goes well beyond just graphene and the isolation of signals from these incredibly difficult to work with nerve pathways. But there are so many fascinating potential applications that this would open up. My question to you, and Gordon, if you want to unmute yourself to be able to answer as well, is the role of graphene in enabling this. Now, graphene isn't, I would argue, the center stage here. What the center stage is understanding, the physiology of the human body and how this all works and to know where to aim this. But how would you describe the role that the graphene material played in enabling this development to take place?
I can start on that if you like, Mario. I think, as Mario pointed out, the characteristics of that graphene electrode are unique in terms of the combination of physical properties, in terms of its mechanical properties, and its electrical properties, and the fact that you can, basically tie it in a knot without changing any of those electrical properties is quite extraordinary. And the reason it's unique is because of the physical form in terms of the sheet size of the graphene, giving the fibers that we spin, wet spinning method, those physical properties, and then the surface area and the conductivity, of course, giving it the electrical properties. So there's no other material that I know that has that combination of electrical and physical properties induced by not just the fact that it's graphene, but a graphene of a particular sheet size formed together in a particular way. But Mario might want to add something to that.
Well, yeah, I mean, that is absolutely true. The first iteration of the reduced graphene oxide electrode was not, it was good, but the signal to noise ratio was not enough. So we need to work on that. And Gordon made a substantial advancement, I believe, in adding the platinum to the graphene, which was not really intuitive, right? So you have a highly conductor already. So why would you need another one? But in this particular case, it helps to collect the charges and the electrons, in a way that allow us for increasing the selectivity, the sensitivity. The sensitivity is crucial. Not only the form factor, but is really the material itself. In order to record, it's very difficult for me to convey how the real challenge in recording from cables that are very, very tiny and that are completely insulated in fat, which is a resistor. So yeah, very unique in that regard.
Excellent. And you mentioned now a couple of times of using graphene oxide, which of course is not conductive, but is it correct, Gordon, that you're using graphene oxide, put it into the form factor, and then you're reducing the oxygen to get back to the conductivity, or do I have that incorrect?
No, that's correct. So obviously the graphene oxide, particularly of a certain sheet size, gives lots of processing and fabrication options, and then we reduce that in order to enhance the conductivity, correct?
Excellent. And I have to ask, because we are the Graphene Council, are you making graphene or buying it?
Now we're sourcing it from different places, and of course that's a very important point, that the quality of the source of the graphene ultimately determines the sheet size that we can get through exfoliation, and we've done a lot of work on that exfoliation process and the control of the reduction process to get not only the amount of oxygen right in terms of getting the conductivity and mechanical properties right, but the distribution of the oxygen. I mean, recently we've been working on edge functionalized graphene, which is highly processable, but all of those processes ultimately depend on the quality of the source. And I think we all know that, all of us who have worked with graphene, that if you don't get the source right, you're not going to get the product right. So.
Absolutely. And that extends to actually characterizing the material so you actually know what you have, which is far, far more complex than I think most people realize unless you're deep into working with graphene. I do have another question that has been raised, but I haven't really seen an opportune time to ask it yet, so I'll ask it now. We know that there are obviously concerns whenever you're using a material in the human body, and so questions are constantly being raised about the toxicity of graphene and using graphene in the human body. And that comes either from the graphene itself or from its form factor. We know that problems with other nanomaterials have been more about form rather than the chemistry. I don't know if you care to speak at all about the issue of toxicological effect of graphene and using it in the body or not. Do you have any comments on that?
Yeah, of course, that's a very important issue, right? So graphene and carbon nanotubes and all, there are, less prone to evoke an immune response if they are pure. Most of the issues that I've seen has been with contaminants, metal contaminants that are part of growing if you're talking about carbon nanotubes or in the manufacture of the graphene. Impurities is a big issue. You gotta have those at a very low level. Graphene, I've seen, and I put graphene and carbon nanotubes in the brain and in other places. You don't evoke a huge immune response. Obviously, the form factor is important as well. In the peripheral nervous system, in the brain, it is known that if you have something that is smaller than 10 micrometers, that gets into the stealth form where inflammatory cells normally ignore that. So with 40 microns, we're in a size which is larger than that, but not too large. But the main answer is, and the real answer is that we are in the process of evaluating the chronic inflammatory response to this material, which we can expect will be less or equivalent to other conductors at the moment, but that needs to be shown.
And I think in one of your slides, you had shown comparisons in conductivity with carbon nanotubes, which obviously are already kind of in a fibrous form factor. Why not use carbon nanotubes? Why use the graphene, which is basically then formed into like a cable?
Right. So carbon nanotubes have been also used before, and I think the graphene is definitely more conductive, and is in my opinion, we try both of them, and we're using the graphene because the sensitivity of the carbon nanotube was not near to the one that we wanted, and in this particular application, the sensitivity is the main criteria for material selection that you probably have to make.
Excellent. I appreciate that.
Just add to that, Terence, that the graphene gives many more processing and fabrication options than the carbon nanotubes do. So Mario's described one form of the sucrose. We're working on other forms of it, and that processing and fabrication end of things is really important too.
Excellent. And I think we could take one really short question on the addition of platinum. Is that primarily as a structural additive, and how difficult is it to clad your graphene fiber with platinum?
It's just a very thin, extraordinary thin layer of platinum that acts as a current collector. The important thing is it does not interfere with the inherent mechanical properties of the graphene fiber. And it's a very simple fabrication step to put that down.
Excellent. I think we're going to have to call it there as we come up to the top of the hour. I really want to thank both of you gentlemen for collaborating on this, sharing your expertise. Congrats on the paper. It's really groundbreaking work. Gordon, thank you so much for getting up at the crack. It's not even the crack of dawn yet. It's before the crack of dawn. So thank you for making the extra effort to join us. And so with that, we're gonna conclude. Thank you both. On behalf of the Graphene Council, I want to thank everybody for participating and for your interest in this sector. Clearly, graphene has a very important future in healthcare applications, whether it be for devices, medical sensing, diagnostics, or even in some of the infrastructure of gowns and devices and elastomer products, etc., that can be enhanced with graphene. So with that, I want to thank you very much. Thank you for your interest in the Graphene Council. If you have any questions, if you need any guidance, if you need information, anything to do with graphene or any of the companies that you saw in the past 2 days, please reach out to us, and thank you for your time and attention.